18 months ago, when we knew, I think it's going to be one of those 9/11 situations, we all knew where we were when our lives changed 18 months ago. Sad, maybe. Anyway, there was word around something going on. We were still working in Emerge. Then there was some discussions being made where we're going to have to start changing policies with the models and the predictions coming in. So that's where it started. It's all based on modeling and predictions of possible waves. So we have to change our way of functioning, our guidelines, with the idea of preparing for what is coming. So that's where it all started. And I'm sure you can remember flattening the curve. That was the focus.
Yep.
Exactly, flattening the curves over the next 2 weeks. If anybody understood what was going on there, it was basically, let's see what we can do in these 2 weeks, could give the hospitals time to prepare if there is a possibility that the predictions that they were coming out with, these modeling, computer modelings, if this was correct, well, at least we gave them the best chance to prepare and maybe ride through this and with the least fatalities or casualties at the end of this. That said, anybody that has been employed through this whole thing, their predictions most of the time was not correct. I can't speak for any other provinces. I can't speak for any other countries, but in our area, the predictions and the extent to what the predictions were going to be never came to fruition.
Right.
Not in my experience. If some of my other colleagues experienced it differently, I cannot say the same. For that first, I'd say at least 2/3 of the year, with all the waves being predicted, we were sitting in the Emerge department, the slowest shifts ever. Our numbers were down. Our numbers were down to the extent that it was becoming a financial implication for the hospital. And how hospitals work of the numbers you see gives them an idea of what you get from the government to run those numbers and function perfectly, and your flow, the amount of time people wait in your ER, all of those things are calculated at the end of the day, and it has financial implications. That said, we were sitting there basically doing nothing through most of these predicted waves going on. Before that, there was some guidelines being brought in saying that if there is a possibility with somebody having a positive COVID contact or a positive COVID syndrome patient, we had to separate these two groupings, which once again makes sense out of a outbreak sense. You want to separate your area of where you're going to be treating the one type of patient, where you're going to be treating the other, to minimize the contact risk, which obviously is logic. The side of it that wasn't very logic was at the beginning of this whole thing, there was no guidelines on who is positive, who could be positive. It ended up being somebody with a cough, and it extended to such a point, anybody with a fever, anybody with a stomach ache, anybody with diarrhea, and it kind of just kept on changing every single week. Now they could have been seen as positive, a possible positive case. Now they couldn't be seen as a positive case because the guidelines recently changed. And all of this was directed by public health. They were in control of this whole story and this whole narrative. They were also in control of who was allowed to be tested with a PCR test. Because if you remember correctly, there was a huge issue with the amount of tests available, that we really had to use the test on the people that had a high probability of being positive. And even then you waited 3, 4, 5 days to get that test back. So all we did, I ended up working at some of their treatment centers right in the beginning, because once again, I run to danger. I don't run away from it. So I wanted to be involved with it. I wanted to be involved if they had a offsite hospital prepared. My willingness to work was kind of met with resistance anyway. I have no idea why. So I ended up just doing my job and Emerge and not doing anything else. But we had such strict guidelines that if people came in with a positive possible COVID syndrome and it kept on developing, that we could tell them, well, you don't really qualify for being tested now. Go home, rest, and we'll see how you are in the next week or so, which raises some flags already if we know about all the issues with alternative treatments and early treatments and prophylaxis in hindsight that we know now. So obviously that's a big group of people that really weren't treated by the system anyway. They were sent home. That said, then the period of testing, the amount of testing we could do changed. There was directives coming through that now every single patient had to be tested if they're going back to school. So that part already didn't make sense to me, especially knowing, because I did a lot of reading on the validity and the sensitivity and the specificity of the PCR test. There was a lot of problems with that test. So if we were making decisions on that test, I should know about it, because it also depends on how I manage and run my ER department, if I really trust the specificity of this test. We had no control of who we were able to test. It was mandates coming through. So during that whole process, for example, if we had a COPD patient coming in, we've got, I think anybody that works in the ER department, you've got your COPDers, your emphysema patient that comes in every single week. You kind of know who they are before they even register. When you hear the description on the ambulance overhead, you register them, you give them their BiPAP, their CPAP, maybe a little bit of Lasix, and within half an hour, most of the time, they're good enough to go again. A little bit of nebulizations. At the start of all of this, there was such a strong recommendation to have aerosol precautions. That's a whole other can of worms with the PPEs that was available, that wasn't available. But basically what it boiled down to, if there was anybody coming in with a possible risk of being a COVID-19 patient, you had to put them in a sealed room, low pressure room, that minimizes the risk for anybody else with the aerosol exposure. So you had these COPDers. I knew them well enough to know exactly how to treat them. I was not able to treat them because it means that I have to take them to a low pressure room if there's any possibility of providing nibs. I couldn't provide nibs in my own department, even for the asthmatics that we know well, because it was an exposure risk to anybody else in the department. So we ended up having to change our management of basic things that we've been managing the same for how many years before, and changing it because of guidelines coming through on something that I questioned already. So the fallout of that, there was so much, I would say, changes that led to a possible way of seeing it as substandard care in a hospital sense already. Code blues. As an ER physician in our hospital, we run code blues. We run up to the ward, we run to the theater, to the operating room. If there is another physician there that is able to take over, they take over so that we can return to our department. But even then, code blues, for those, the listeners that doesn't know, code blue is literally when somebody arrested and you have to do CPR, resuscitative process. Time is of the essence. Everybody knows that every single minute counts. As soon as you can start compressions and ventilation, that does make a difference in the recovery of that patient and the long-term results of that patient's quality of health. So with code blues, we weren't allowed to start if we didn't have PPE on, our N95 masks. We couldn't do at the beginning, we couldn't even do resuscitations when they were brought in by an ambulance before we got them to that low pressure room. So as I asked questions, because my personality is, and I think my job as an ER physician is to ask questions. If I'm the one that is that barrier between the outside world and the hospital before you get admitted, it is my job to be a detective and try to get as much information in as little time as possible and screen what is important, what is not important, what is relevant and what is not relevant. And there were so much things that did not make sense to me because we weren't treating the patient in the best possible way that we are able to because of certain guidelines. Guidelines are great. We all need guidelines, but guidelines without any valid backing of scientific research, and I'm not talking about just quoting something that was heard on the news, a proven study, meta-analysis with controls that had proof before all of this broke out. If that wasn't there, then you should question the guidelines, because guidelines is there as a guidance for you to start following a certain narrative. But if it doesn't make sense in your clinical practice, it is your job as a physician to question that. And not to question, that's not the end game. The reason you're questioning is because you are That is part of the scientific process. You've got a hypothesis, you question it, you adjust it, and then you get to a point where we said, well, this is probably the better direction to go into, and we can adjust to a new guideline. That was not happening at all. And in fact, as a lot of your interviewees probably know, as soon as you start questioning, there was really a sense of what is your agenda? What is your intent? And there was a kind of a way of censorship. So jump a little bit forward. So that was the first, I would say, probably at least the first 8-9 months of my experience through this whole pandemic. Then we did start getting busier, not with COVID patients, weren't overloading our ERs. We were just starting to follow the usual trends as an ER. We are a busy hospital. We are a stroke referral center. We are a little bit of a larger hospital in this community with smaller towns around us. So now we were kind of getting back to normal ER numbers, not fully functioning, but ER numbers. And we felt overwhelmed just because of all of these guidelines where we weren't able to have our normal flow in our ER like we would have had before. Jump to 2021, and that is where my whole experience during this whole pandemic really changed. And this statement is a statement of causality. There's no proof behind it, but my experience in the ER pre-vaccination or pre-Pfizer Moderna rollout and post-Pfizer Moderna rollout was way different from personal experience. After the rollout started happening, I started seeing our emerge department getting busier, more complex patients, cardiovascular concerns starting up, definitely an increase in our amounts of strokes, younger people coming in with strokes, TIAs, headaches without any real diagnoses, without any basis of starting, hypertension, newly diagnosed diabetics, ischemic type of changes, peripheral vascular ischemic type of changes. And these are things that as an emerged physician, you do see these, but they're not the majority of the patients that you see in emerged department. Acute injuries, chronic disease is definitely, unfortunately, a part of our job, but it kind of felt like it was taking over all of my shifts. And once again, I started asking questions because that is my job. I started asking the question, if this is what I was seeing, and I read a lot because if I wasn't getting the answers from my peers or from the specialists in my hospital, I felt it was my responsibility. As soon as I'm done with my shift, I didn't go and rest at home. I went to go read for answers because I was looking for something to guide me. And how was I able to treat these patients coming in or actually just get to an answer? And I started reading up more. And during that time period, there was new literature coming out on how they explained the whole COVID-19 syndrome. And the focus did move from a respiratory virus to a microvascular, if we want to put it in that way, microvascular disease. And I found it very interesting that the people that I was seeing fit that picture pretty well. It was microvascular things coming in. They presented in different ways with rashes, kidney failures, things like that. But if you understand the underlying physiology behind it, it made sense that a lot of these patients' connection possibly was microvascular thrombosis. And I just started reading up more. And that is where I started asking almost every single patient that came into my emerge department about their vaccination status. I've never done that before. And the fact is that I had to do that kind of gave you the idea of where I was moving from already. The sad part, these patients, as soon as I asked them, did you get the shots or did you get the injections? They would be very adamant to make sure that I know that they did their part. They are double vaxxed as they are lying in my bed. This is full disclosure. As soon as I heard that, I knew my job became a little bit more difficult because there was something possibly going on. Once again, this is maybe a point of causality, who knows? But the point is we don't know. But from experience, this patient lying in front of me with my 16 years experience in the medical field in different countries and different subsets, that job instantly became more difficult. And I had to put so much thought and intent of how I managed this patient because I knew that there was something that I was missing. And I need to put my finger on it. And I didn't have the answers, and nobody was willing to even listen to me asking the questions of what is going on here. I ended up doing D-dimers because most people would know about doing D-dimers. We do D-dimers to rule out PEs. We love and hate a D-dimer level because as soon as you get a positive level, you have to do something to either disprove or prove the fact that there may be a deep vein thrombosis or a pulmonary embolism. But I ended up doing D-dimers on these patients because I had a hypothesis. If there is micro thrombi happening in their body that we are missing because we're not even looking for it, maybe there's a way to either disprove it or prove it. And unfortunately, Mark, it's not a family physician office. I don't have the numbers of knowing exactly how many people I ordered the test on. But what I can tell you is that the amount of positive D-dimers I picked up in just our one ER department was through the roof. It was becoming almost a joke of when I did it, when it came back and they would hand you the piece of paper flagging it, saying it's over 3,000, over 5,000, I'll just take the piece of paper and say, well, thank you. I knew it was probably going to be high. So part of me getting a positive D-dimer, anybody that's worked in Emerge or a family physician, once you get that taste, you kind of have to make a decision on what you're going to do further. The usual way of treating a D-dimer that is positive, if you had a high suspect or a high probability or suspicion of a clot somewhere, you would go ahead and do a CT scan because that is the only definitive diagnosis on a blood clot. It's either ruling out or confirming a pulmonary embolism or doing an ultrasound of the legs to see if there's a blood clot somewhere. In the beginning part of all of this, I ended up doing a few CT scans on these people, expecting there to be a large blood clot in the lungs or somewhere that I would only be too happy to pick up and see if we can start treating with anticoagulation medications. There was a few people, or most people, that had negative CT scans. So I had to make a personal decision, a clinical decision at that point, that obviously what I was taught before and the way of using this D-dimer in my department wasn't really fitting the picture here. So now I'm stepping into an area. Am I putting these patients at an even greater risk of doing CT scans that is not really giving me any more information and basically just proves that they are healthy, that there's nothing going on with them?
Right.
But as we know, a D-dimer is still a very important test because it's one of those tests that shows you that there is a coagulation pathway happening. In that coagulation pathway, thrombin is being broken down and fibrin products are being made, and that is why the test is positive. So it still proved to me that there was somewhere in these patients' bodies microthrombi happening that we were not picking up with our usual testing. I ended up doing ESRs and CRP on these patients as well, because the issue is we still don't know what is triggering these D-dimers. Is it an autoimmune basis? It is an overwhelming inflammatory basis, and you're absolutely correct, Dr. Charles Hoff, and there are some couple others, Dr. Bridle and all of them that have come out, that there is a possible connection between the cytotoxicity of the spike protein and the damage it does to the endothelial system. That only recently they kind of confirmed with the spike protein on the COVID virus. My question that came out of that was, why would we confirm the basis and the causality of the spike protein in the virus, but not make that connection possibly with the injection that you were going to be giving to millions and millions of people? And afterwards, there has been proof that came out that that spike protein does not stay where it was meant to stay. So the connection between that spike protein and what was happening in the endothelial parts of these people's bodies, especially small microvascular areas, that connection is there. But at the end of the day, I still didn't have any specific answers on how to treat these people. When they started coming in, and even before the rollout, if there were people coming in with kind of congestive heart failure type of pictures, more than what I would usually see, I would say, well, there is doctors actually doing research on how to treat these people and not send them home. And if I ended up admitting a congestive heart failure or even a pneumonia, because a lot of my diagnosis ended up being pneumonia, what I was seeing on the X-ray was pneumonia, nothing else, nothing new, bacterial pneumonia. with a positive PCR test. If I ended up admitting them with that diagnosis, I would like to treat them with something. And I ended up asking a few of our specialists saying, well, there is these very smart people with very good credentials in the US that have been researching this specific point. And ivermectin obviously was included with one of those treatments, but their protocol wasn't based on only ivermectin.
No.
It was based on steroids. It was based on vitamin D, vitamin C, zinc, melatonin. And I actually had copies of the MASC protocol. I had copies of the MATH protocol that I printed off if I ended up sending people home where we said, well, you have something going on, some or other virus or low radiation, whatever the basis of it was. There is something that you can take to a pharmacy or a health food store and at least go and support your immune system to get you through what we are adjusting to in our environment. When I ended up asking these specialists, when I ended up admitting people where I felt that I couldn't send them home safely, and I asked them on these things, the easy answer was, well, it hasn't been proved safe or valid by the National Institute of Health. And I remember one comment specifically to one specialist where I said, well, you know why? Because there was a politicizing of this whole issue. And there's actually a lot of proof that there are alternative treatments. And a lot of these treatments is basically just supporting a person's body, decreasing the inflammatory process that's going on so that you give them the best chance to go on. And I mean, obviously, I think your listeners are probably the more informed part. There is a lot of concern with the way that they were managing people that was seen as a COVID patient being admitted to their wards and to their ICUs. I don't have to go into the details of that. But what I want to do is just touch base again with you mentioning the hospitals and the overflow and how kind of overwhelmed with patients they were. I can't speak. I did not work in the ICU. I managed codes in the ICU. I never worked in the ICUs. I did not admit the amount of patients to the ICU that would overwhelm our ICU. But what I can tell you is that there were certain wards being closed, certain areas of our ICU that was closed because of staff shortages and because of other reasons, apparently, that our amount of beds became less, not more. And then there were also a time period where their patients were being transferred from other provinces to our hospital without any real indication of why would they be transferred to our hospital that apparently are dealing with an overflow already. And they would be closing wards for breakouts where there was positive PCR tests on patients, and this can be confirmed. A whole ward shut down because there was 6 PCR positive patients in that ward. Shut the whole ward down. Anybody that worked in that ward was shut down. If you know the functioning of a hospital, that is a huge, huge setback for a hospital because elective surgeries are basically banking on the fact that I booked this patient for this surgery, but that patient has a bed either for a day or two in the recovery process. Elective surgeries were taken off the table. A lot of things were canceled because of that. Later, it came out that I think it was 6 or 7 people that tested positive with a PCR test. I think 6 or 5 of them was asymptomatic. Asymptomatic PCR positive tests, and one mildly symptomatic patient caused a whole ward to be shut down, I think for at least 2 to 3 weeks. And I have to confirm, I don't know that specifics, 2 to 3 weeks where that ward was shut down because of that. The other word for asymptomatic until 2020 was healthy. So you shut down a ward for 6 healthy people and reshuffle the whole department and all of the staff working there for that PCR positive test without backing of any serology of antibodies or any inflammatory markers to see how sick are they. If they are asymptomatic, obviously they have a viral load or there's something going on making you concerned enough to close down that ward. That did not happen. So it happened in the beginning of this pandemic, it happened in the middle, and it happened at the end, where decisions were being made on apparent modeling projections and guidelines, where the logic that was followed pre-2020 and the logic that was followed post-2020, there was no connection between the two. And my issue with that is that I think it will be almost impossible to determine the fallout of this whole pandemic, because it is literally impossible to see how many people were supposed to have surgeries, how many people were supposed to be treated for things, how many people decided to stay away from the hospital because they were so afraid of dying of COVID. Yeah. And what is the long-term implications of that? And if we are really trying to get to the bottom of this, suppressing alternative treatments, not assisting people equally in the hospital system and managing people equally, where you should have priority if you are an oncology patient waiting for surgery compared to a patient with a positive PCR test. And those things weren't happening. So I think a lot of that, Sam, a lot of that built up to that day of the 23rd of August, that I had so much to say, I had to hold back so much, because that wasn't the point of that meeting. The point was literally to prove that I've got questions, valid questions, not even hypotheses and complex stuff that I've been dealing with, just questions on your policies that was not making sense. And the reason I asked that, if my emerge department was already overwhelmed with I think at that stage, maybe it was a 60% vaccination rate, and you suddenly decided in a time period of 2 to 3 weeks to make that rate 85 plus, now it's 90 plus that should be positively vaccinated, double vaxxed. What is the implications for your health system? That's the first part. If you consider the fact that there are side effects to this, and there's no way for you to determine those side effects yet because there's not enough data, shouldn't you be prepared at least for a possible setback in your own staffing situation if you are going to be mandating this? And the second part of it, if you do not give healthcare workers the choice to take this treatment and they just end up deciding to leave, that has implications for that hospital again. So standing on the basis of the moral high ground, which unfortunately he did try to take at the end of that meeting, the moral high ground of I am just standing up for the safety and best interest of these patients in the hospital, I would strongly disagree. If you are running an ICU department on only 3 nurses, because the rest of your nurses left their jobs, and now they have to treat 7 ICU patients instead of 3 patients, I would strongly disagree that you are not providing the safest medical care that you promised to be providing. I just want to introduce myself. I'm not sure if everybody on the call knows who I am. My name is Rujane Killian. I'm one of the ER physicians that's been working at Grey Bruce for the last 4 years, happily employed with the Grey Bruce Corporation so far. But I do have a few questions, if you would allow me the opportunity to ask those.
Please, go ahead.
Okay. You did answer a few of my questions already regarding the exemptions, and I did want to ask the first one. There's going to be a couple, but the first one is, who decides the validity of the exemptions? Who decides which one is going to be accepted and which one is not going to be accepted?
Hi, Dr. Killian. It's Rebecca Cummings. In my portfolio, I have occupational health and safety. And so within the directive that has most recently come down from the province, there are some clear guidelines on exemptions. They're quite strict. And requests for medical exemptions will come into our Occupational Health and Safety Department for review, and they will be approved through that process.
Okay, thank you for answering that. My next question is related to the Ministry of Health Ontario's most updated August 17th consent forms. It has been changed since I received it 2 months ago. But my question is, why is it, as part of the informed consent, why is it not stated on the Ministry of Health's forms for the vaccine screening and consent form that these biologics are still in clinical trial phase?
Okay, so we don't have oversight or input into those consent forms, so that's not really something that we can answer.
Okay. Although it might be something that you should consider if Grey Bruce is following the mandate or the guidelines to mandate this. I mean, it should be part of the research being done on why this information is not provided on the consent form, but I understand if you can't answer that.
So Dr. Killian, I would say probably in a pandemic, some of those pieces that you think would be there when you have lots of time to review stuff and that kind of stuff, over time for research, et cetera, and running this all out, it's quite normal to have it if you have lots of time. But in a pandemic, they're going to pass mandates and they're going to pass laws and they're going to pass directives as needed to manage that pandemic. And some of those things that they do will feel like they're infringing on or taking shortcuts or taking, a quicker move left or right. They're doing that directly to save lives. And they're probably communicating in a way that makes it as simple as absolutely possible. They're probably not thinking about how they might communicate with an infection control specialist or an emerge doc or a lawyer. They're thinking, this is the directive we have to make. It has to be at a grade 5 level. It has to be very straightforward for people to understand. And that's how they put them out. Now, I will promise you, there is a massive scientific group that reviews all of this. And when we're on calls with these guys, they're all there. Every PhD, MD, infection control specialist from across the province and the country sits on those specialty panels. And when they do this and approve them, they're not just doing it out of the ministry, they're doing it with that scientific group. So, I unfortunately have to fall to that scientific group and its direction. And of course, the ministry are the ones that are issuing it, not ourselves. So, we're following what those directives say.
Okay. I do want to, on that specific note, according to the Tri-Council policy statement on human research, there's ethical conduct for research involving humans. There are 3 principles: respect for persons, concern for welfare, and justice. And all 3 of those principles do dictate that even during an emergency, the emergency state that we're in does not allow the right for basic principles of informed consent and informed refusal to be taken off the table. I do have a follow-up question as well, but I do want to make a comment on the opinion.
Let me answer that though. Nobody's forcing you to do this. You have a right to say no. But the reality is the government has the right to say you're not employed.
Okay, I understand.
That's the unfortunate part of this. I don't like it any more than you. I think there are lots of challenges that will come out of this post. But when the law looks at it, the law is saying you have the right to do it. And believe me, if there were any laws, including the ethicists have looked at it, if there was any law that would have stopped this, it would already be stopping it. And it isn't stopping it. We're actually not going first. We're following to see and make sure that we're doing the right things the right way. So we're actually a little behind the curve. But you will find those big hospitals that have acted, they have not acted unknowingly or unaware of those facts.
Okay, that's perfect. My last question, before I just want to make a statement. I see in your letter that you send out regarding this Zoom meeting that COVID-19 cases in our region are increasingly circulating among those that are unvaccinated, as are the patients being admitted to the ICU. I do have a question. Every single patient coming into Grey Bruce Health Services, are their vaccine status persistently recorded, and what constitutes being unvaccinated? Is it no vaccines? Is it only one vaccine? And if this is recorded, where is the database for this statistics? And do we as staff of Grey Bruce have access to this?
So you won't have access to it as staff because that's private information. It will be held, there will be one in Occ Health for what we know, and the reason we're asking for the form is to clarify any risk factors associated with that. Public Health should have, and it does have, a database for those that have been partially vaccinated or fully vaccinated, and that sits with the province. So it's not public because that could cause people to act against other people that have a different opinion on vaccinations. And so all of that is like health information that is not open to the public.
Okay, but making a statement that it is the unvaccinated being admitted to the ICU, is there a database at the hospital to provide the backing for that statement?
No, but there is. So I will tell you provincially, that is what we're seeing. And that there is a database for that, but that's calculated by the larger hospitals doing an inventory across the province. So, okay. and this is not a debatable percentage. The lowest percentage measured is 80%. The highest percentage is 97%. And of course, you've got people that legitimately can't be vaccinated, or they're pregnant, whatever, immune suppressed, whatever the circumstance may be. But the last calculation I saw, and it changes every week, of course, because the numbers are changing, was that less than 0.7% of the people that ended up in ICUs were vaccinated. So you know that the largest percentage possible, short of 100%, it's vastly those people. The greatest fear, quite frankly, is that that's not really what's going to be the issue. It'll be the pediatrics that's the issue in the fall. And if there was ever a division between personal rights and civil and social rights, you will see it this fall if children start to die, because there will be an uprising by the people who have children or the people that are vaccinated that might get not nice at all. And as an organization that cares for those people, we have a responsibility to protect them. So, I personally believe we have to do this. Do I want to do it? No, I don't. I wish I could respect everyone's rights, not affect anybody in any way, and allow them to do what they want. But right now, Delta's not letting that happen in real life terms and time. So as long as it's not in our community, people can say what they like, but it will come here. It will not avoid us. We had the first wave at 4, and we saw it. And it was all unvaccinated that we saw. And it was a small blip at the start, right at the end of 3, and we got trapped for 2 or 3 weeks, not being able to roll out our surgical stuff, etc., because of it. But the reality is, we should expect to see a lot more in wave 4.
Okay, Mr. Sims, I'm respectfully going to disagree. If saying out of history that there was an upsurge, but there's no proof of that data, let's agree to disagree on that. I did see that Dr. Newton mentioned that the FDA literally 40 minutes ago approved the Pfizer vaccine. That unfortunately makes you question the validity of the FDA, because no clinical trial until their completion can be fully approved, and the Pfizer preliminary trial ends on the 2nd of May 2023. But that said, I think I'm going to not take up much more of your time. I do appreciate you taking the time to answer my questions. I am gonna on this meeting, I do want to state officially for the record that after 4 years, Dr. Ruzhana Killian, will be resigning from Grey Bruce Health Services effective immediately. I will provide an official letter providing the information and the reasons why I'm resigning, and that I can no longer be complicit with the rules and mandates being placed. And I will stand for the doctrine of second opinion. So anybody that wants to contact me for that information, I would be more than willing to provide that, because the doctrine of second opinion has not been seen in this whole year and a half. But on that note, I will provide that letter, and I ask that that letter be officially recorded in this meeting as well.
Well, thank you for your opinion, Dr. Killian. We always respect people's individual rights. I would tell you, though, you probably need to speak to the scientists and the professionals on this. But, you can delve where you wish. I will tell you, my job is to keep patients and staff protected and safe. And I will tell you, I will follow what the top scientists in the country and the world are saying. And that's what they're saying. So I trust their data. I trust what they're saying. And I believe it's the right thing to do. And I think the amount of people we're seeing sick in hospitals right now that are unvaccinated is a clear example, whether you agree with it or not, that the vaccine is working. And the people that are not vaccinated are getting sick, and that's going to get worse. So,
Mr. Sims, I appreciate and I respect your opinion. I will stand for those that are being censored at this moment. Thank you so much.
Thank you so much, too. Just remember, at this point, they're not being censored, but we may still reach 92% without the censoring. But let's see where we end up. But you can stand where you wish. And I did understand you were leaving anyway, but thank you anyway for your stance.
I do want to clarify that point. I was taken off the official roster so that I would be available on locum status, but I kindly revoke my own privileges at any of the Grey Bruce Hospital services.
Okay, thank you. Another question?